5, 4, 3, 2, 1. Good morning, and thank you for the kind introduction. I'd like to thank the PCOS Society of India for this special invitation. In particular, I'd like to thank Professor Duru Shah. I've been asked to give 2 talks, and this is the first. Does the trigger matter? These are my disclosures, and this is the outline that I will follow. Human oocytes are arrested at the prophase stage of the first meiotic division. It will then require exposure to the LH surge to initiate oocyte maturation. Oocyte maturation is critical to the success of IVF. And when you talk of oocyte maturation, you require nuclear maturation and cytoplasmic maturation. The end goal of nuclear maturation is the formation of a metaphase 2 oocyte, whereas for cytoplasmic maturation, you require the spindles, the mitochondria, the smooth endoplasmic reticulum to be in their proper place. There are surrogates to LH that may initiate the final oocyte maturation process. These are your HCG, your GnRH agonist, your recombinant LH, and your kispeptins. We will go through each of these along the way. Your HCG trigger is your pioneer trigger for final maturation of your oocyte. It is very similar to your LH, and it is almost similar except in its beta HCG subunit. It allows progesterone secretion by maintaining the corpus luteum, and it is linked to peri-trophoblastic immune tolerance, facilitating the trophoblastic invasion and allowing fetal growth in the endometrium. The doses have been discovered. 5,000 to 10,000 units of urinary or recombinant at 250 to 500 micrograms are needed. And the higher the dose given, it can influence a longer duration of action, and this can be beneficial in patients with high BMI. Comparing your HCG to your LH, it has a far longer half-life with more cyclic AMP and steroidogenic actions. But it is also associated with an increased OHSS risk because of exactly the same, the long half-life. It also has luteotropic action and the release of vasoactive compounds such as your VEGF. Remember that your HCG trigger is the one that initiates the wheels of your OHSS given an ominous clinical background. Comparing your urinary HCG to your recombinant rHCG, you have your 10,000 units of your urinary HCG compared to your 250 recombinant HCG. There are more impurities with your urinary, more batch-to-batch variability, and a higher risk of immunologic reaction. So your recombinant HCG is better tolerated by patients. But comparing them in a Cochrane meta-analysis, there appears to be no difference in the rates of live birth rate, ongoing pregnancy rates, or the chance for OHSS. Let's now talk about your GnRH agonist trigger, which was first proposed in 1990 and is widely popular with the introduction of your GnRH antagonist protocol. Now, in a meta-analysis by Youssef, he found that it would cause a lower OHSS rate, but a lower live birth rate, lower ongoing pregnancy rate, and higher rate of early miscarriage. So they identified the advantages, the induction of your FSH and LH, promoting LH reception, increasing your cumulus expansion, and causing nuclear maturation. It also promotes your final oocyte maturation in synergism with your LH, and therefore, it also eliminates your severe OHSS. It is the favorite in fertility preservation cycles and preferred in oocyte donation cycles for those reasons. In a study comparing the different types of GnRH agonists, streptorelin, gluprolide, and buserelin, they found no superiority of one analog over the other in terms of ovulation rates. But your GnRH agonist trigger is only sufficient to induce oocyte maturation. It is not enough to maintain the corpus luteum. And because of this, there is a reduction in your pregnancy rates and an increase in your pregnancy losses. And this is mainly because of your luteal phase insufficiency. So there have been a few options given to try to overcome this problem. These are the options: low-dose HCG at the time of oocyte retrieval, using a dual trigger protocol, very low doses of HCG, fixed low-dose HCG, recombinant LH in addition to the GnRH agonist, and also intensive luteal support using progesterones. In a study comparing your recombinant LH and your urinary HCG, they found that with the recombinant LH at 5,000 to 30,000 international units, it will be effective and comparable to the results with your 5,000 international units of your urinary HCG. But your recombinant LH is not commonly used. It is expensive and cumbersome in administration, and therefore offers no additional advantage over HCG. The last group will be your kisspeptins, which are potent stimulators of your HPO axis. They signal directly to your GnRH neurons, leading to the release of your GnRH in the portal circulation, secreting, therefore, your FSH and LH from the anterior pituitary. And they have identified the doses of your kisspeptin so that they would be effective in ovulation. In a study by Ibarra comparing HCG, GnRH agonist, and kisspeptin, they found that the kisspeptin group had the lowest OHSS profile, the most non-affected with OHSS, the least in mild, and zero, moderate, and severe. So this is far better than your HCG and GnRH agonist triggered groups. Therefore, they recommended it as a natural option for induction of ovulation because of its effectiveness in eliciting an LH surge and with the reported successful live births and the elimination of OHSS. So essentially, these surrogates will be acting based on the duration of action of these substances, with your HCG the longest and your kisspeptins the shortest. The criteria for giving ovulation trigger in ART is based on known parameters: 2 to 3 follicles over 17 mm, estradiol range between 1,500 to 3,000 picograms, and these are already well documented. However, occasionally you are not able to get some follicles and you label them as empty follicle syndrome. These are the lack of oocytes retrieved despite adequate ovarian response and meticulous aspiration of follicles. The etiology seems to be uncertain. It might be human error, it might be pharmaceutical error, or it might be because of pathophysiologic reason. So it is potentially solved by changing your HCG trigger to your GnRH agonist trigger. With this, there will be the release of your FSH and LH, promoting adequate follicular maturation, preventing empty follicle syndrome. Now, there are other situations which can result in a suboptimal response to your GnRH agonist trigger. And it is reported to be about 5.2% in terms of incidence. They identified risk factors: baseline LH below 0.1, serum LH on the trigger date to be below 0.5, long-term oral contraceptive use, low BMI, suggesting hypothalamic dysfunction, and your PCOS, especially those with high numbers of follicles. So it must be important to identify patients with these risk factors. For instance, your PCOS patients, they may have a suboptimal response because of the inadequate neovascularization due to more intermediate follicles. So with this, there might be more immature oocytes retrieved. So the solution is to give another GnRH agonist trigger 12 hours after the first dose to maintain the sustained level of gonadotropins. and the result would be a higher number of mature oocytes and a higher pregnancy rate. Let's go to one innovation, which is your dual trigger. This is designed for high responders. This is first defined as a combination of your GnRH agonist and a low-dose HCG of around 1,000 to 2,500 international units when you try to trigger. In a meta-analysis by Ding, using 527 high responder women coming from 4 RCTs, they were trying to compare the efficacy of dual trigger compared to HCG alone. And they found no difference in the number of oocytes retrieved, the number of mature oocytes retrieved, fertilization rate on day 3, and implantation rate, but there was an increase in the pregnancy rate in the GnRH agonist supplemented group. In another study comparing the effects on the degeneration of OHSS, Shen et al. Compared the results in the GnRH agonist only, GnRH plus 1,000 IU HCG, plus 2,000 IU HCG, and plus 3,000 IU HCG, and found that it was only in the GnRH agonist and the GnRH agonist plus 1,000 IU HCG to have eliminated your moderate to severe OHSS. Also, there were more oocytes retrieved, more embryos generated, and more high-quality embryos generated in the GnRH agonist plus 1,000 IU HCG compared to the GnRH agonist alone. So they concluded that the best group would be your GnRH agonist plus 1,000 IU HCG to eliminate OHSS and yet have better oocytes, embryos, and high-quality embryos. So the advantages of dual trigger appear to be it makes it more physiologic, the GnRH agonist component, because it releases both endogenous and FSH and LH to increase the number of mature oocytes. The HCG portion will support the corpus luteum. It will potentially enhance endometrial receptivity, and it will lead to higher levels of amphiregulin and epiregulin, which is important in cumulus expansion and oocyte maturation, and of course, decreases your OHSS risk. There's another technique, the double trigger, which is intended for your poor responders or decreased ovarian reserve, your normal responders, and those with abnormal oocyte maturation. The combination is described as GnRH agonist with a standard HCG, this time at 5,000 to 10,000 international units, initially suggested at 40 hours and 34 hours from ovum pickup, respectively. So this will prolong the time from ovulation trigger to ovum pickup, and it will overcome any existing granulosa cell dysfunction, facilitate cumulus cell expansion, and you will be able to retrieve more mature oocytes. So this will result in a significant increase in oocytes retrieved and also high-quality embryos generated compared to your HCG. And these are the schemes that were suggested by Orvieto. He suggests that for poor responders, you give both GnRH agonist and your HCG at 34 hours. For normal responders, you give them at 36 hours. And for those suspected of having abnormal oocyte maturation, with your GnRH agonist at 40 hours and your HCG at 34 hours before OPU. Now, let us cite a few studies. So this is double trigger compared to HCG trigger alone in poor responders. This is by Haas, and he found that the double trigger group will have shown to have more oocytes retrieved, more 2PN embryos generated, more top quality embryos generated, also more positive HCGs and higher clinical ongoing pregnancies. This is by Lin et al., also comparing GnRH agonist double trigger with your HCG trigger alone in diminished ovarian reserve, and they found a increase in your fertilization rate in your double trigger group, and also an increase in your clinical pregnancy, live birth, and decreased abortion rate also in your double trigger group. And this is in normal responders, a study by Gao et al., where he found more oocytes retrieved in your double trigger group and more 2PN embryos and more embryos available in your double trigger group. So the indications for both the dual trigger and the double trigger appear to be for groups where there is a subset of greater than 25% immature oocytes retrieved, those with empty follicle syndrome, to prevent OHSS in high responder patients, and also those with poor responders. So if you would like to individualize for these combination trigger protocols, the dual trigger is intended for your high responders using your GnRH agonist plus a low dose HCG, and you will increase your mature oocyte yield, you will rescue your corpus luteum, and improve your pregnancy rates and reduce your OHSS rate. You will also have your double trigger protocols, first for the normal responder group, where you give your GnRH agonist plus the standard HCG of about 5,000 to 10,000. You will result in much more mature oocytes, more good quality embryos, and more for cryopreservation, but this is not intended for fresh transfer. And finally, for your poor responders, your GnRH agonist with standard HCG is given, and it will result in more total oocytes and mature oocytes retrieved with better IVF outcome. So that was my last slide. In summary, time has come to individualize the choice of ovulation triggers for final oocyte maturation for patient safety and improved outcome. There are 4 surrogates of LH that can be used: HCG, GnRH agonist, recombinant LH, and kisspeptins. Of these, GnRH agonists stand out because their ability to decrease the risk of OHSS in ART. However, beyond preventing OHSS, there are other issues to control: high immature oocyte yield, low total and mature oocytes retrieved, empty follicles, and low CPRs and low low live birth rate when using your GnRH agonist trigger. So to address these problems, there are new trigger protocols, the dual trigger and the double trigger, which are approaches using your GnRH agonist with HCG in varying doses and timings for high, normal, and poor responders, resulting in decreased complications and better ART outcome. Indeed, the type of trigger matters. Thank you very much. Cut.